Hey everyone. Okay, let's dive right into this incredibly important explainer on, well, how we handle our final days. Today we're unpacking a really fascinating 68-page doctoral dissertation by Elizabeth Armstrong-Fears. Our whole goal here is to take this highly complex scholarly document and transform it into something that you and I can easily understand, appreciate, and honestly apply to our own lives. We're looking squarely at the intersection of healthcare leadership, cultural assumptions, and the profoundly sensitive topic of end-of-life planning.
Because think about it, if you couldn't speak for yourself in your final days, who would? It's a heavy, deeply human question, right? And it sits at the very core of today's analysis. It anchors us in the agonizing reality that families face when there just isn't a clear plan in place. When we talk about data and statistical models, it's so easy to lose sight of the human element. But behind every single percentage point we're about to look at, there's a patient, a grieving family, and a medical team just trying to do the right thing when time is running out.
To make sense of all this dense research, here's our roadmap. We're going to cover 1. The end-of-life care problem. 2. The purpose of the study. 3. Testing the ethnicity assumption. 4. The surprising study findings. And 5. Implications for healthcare leaders. All right, let's get into it. Section 1. The end-of-life care problem and the human experience at the center of it all.
Honestly, when you look at the research, the scale of this health crisis is just absolutely staggering. According to the Centers for Disease Control and Prevention data cited in this study, there are more than 8 million people in the United States currently living with absolutely no kidney function. 8 million! Take a second to really think about that number. That's literally roughly the population of New York City, all navigating a highly vulnerable phase of their healthcare journey. This condition is medically known as end-stage renal disease, or ESRD. Basically, it's stage 5 of chronic kidney disease. At this point, normal filtration in the body has decreased so severely that it's life-threatening. It requires constant dialysis or a kidney transplant just to survive. So, patients suffering from ESRD face incredibly tough, life-altering medical choices every single week, but especially as they approach their final days.
And right here is where the critical problem emerges. Without clear advanced care directives on file, the massive burden of deciding on life support, artificial nutrition, and continued dialysis, it falls squarely on the shoulders of grieving family members. This lack of planning creates a chaotic, emotionally devastating, and just painful end-of-life experience. Instead of a peaceful transition where the patient's wishes are honored, well, families and doctors are literally left guessing.
Moving on to Section 2, the purpose of the study, and defining our scope.
With the problem this massive, you really have to define a specific scope to find any real answers. For years, established literature just assumed a huge ethnic gap existed in end-of-life planning. Previous studies suggested that African Americans use hospice less and prolonged treatments more than European Americans, usually attributing this to cultural mistrust of the medical system or spiritual beliefs. So our researchers set out to test a very specific objective. Does ethnicity actually dictate who makes a plan? If you're an ESRD patient 55 or older, does your racial background actually predict your planning behavior?
The crucial thing to note here is that the researcher didn't just ask vague questions. She narrowed the focus down to 3 specific variables. First, did the patient have written end-of-life care instructions? Second, were there documented treatment decisions specifically for those final days? And third, was the elderly patient actually able to participate in those decisions? The whole goal was to see if being African American or European American made a statistical difference in any of these 3 areas.
Which brings us to Section 3, testing the ethnicity assumption and the study's methodology.
Now, in academic research, you can't just survey a dozen people and declare it a fact, right? You have to mathematically prove your sample size is large enough to trust. What you're seeing here is a G-power analysis, calculating the minimum sample size for logistic regression. It's a strict statistical check to ensure the study's results are absolutely bulletproof and not just some fluke of a small sample.
Armed with that rigorous mathematical framework, the researcher turned to a massive, highly respected secondary data set, the Health and Retirement Study. By tracking adults across 4 different waves from 2010 to 2016, she pulled exit interviews from 1,299 actual patients who died from kidney disease. These interviews were conducted with proxies, family members who actually knew the deceased. This gave the researcher a highly reliable, real-world data set to dig into.
All right, Section 4, the surprising study findings and the major twist.
Get ready, because the numbers here completely flipped the established narrative on its head. First, let's look at the baseline reality. Out of everyone studied, all 1,299 patients across the board, over half, 56.9% to be exact, passed away with zero written instructions for their final care. No way around it. That's huge. More than half of these patients, knowing they had a terminal, life-threatening kidney disease, never formally documented what they wanted to happen at the end.
And here is the twist of the entire dissertation. The expected myth was that the data would show massive ethnic disparities in who was actually planning. But the actual reality? The statistical models prove that ethnicity was not a significant predictor at all. The assumed ethnic gap just wasn't the real story. The real story is that almost everyone, regardless of whether they were African American or European American, is universally underprepared. It's a systemic issue, not an ethnic one.
But wow, the data gets even more concerning. Even for the minority of people who did take the time to write down their instructions, it often didn't even matter. The study found that for a shocking 75.9% of the people who actually had written instructions, those documented decisions weren't even used in their final days. Think about that. The breakdown in communication between the patient, the family, and the clinical team was so severe that the plans they made were essentially ignored or lost when it mattered the absolute most.
Finally, Section 5, Implications for Healthcare Leaders and the Call to Action.
We really have to ask the most important questions of any doctoral study. Why does this matter? And what are we supposed to do with this surprising data? Healthcare executives aren't just morally obligated here, they're ethically and legally bound by the Joint Commission to honor a patient's rights for culturally appropriate care, exactly as written at the end of life. But doctors and administrators are put in an impossible bind, aren't they? They can't honor what they don't know. If wishes aren't documented, or if they are but aren't effectively communicated by the clinical team, the system completely fails the patient.
So, the social change demanded by this research is pretty profound. Hospitals and clinics absolutely must adapt. Leaders need to create standard workflows for early end-of-life conversations, normalizing it early in the disease progression and completely removing the stigma. We've got to transition deeply into value-based, patient-centered care where improving physician and family communication is a top priority. And practically speaking, IT systems need to ensure these advanced directives are highly visible in medical records so they're actually used, preventing that tragic 75% failure rate we saw earlier.
This dissertation clearly proves that just hoping for the best isn't a plan, regardless of your background. It's a universal problem that requires a universal solution. So I want to leave you with this final, incredibly important thought. If the unthinkable happens tomorrow, does your family know exactly what you want? Thanks for walking through this critical explainer with me today. Seriously, take the time, have the conversation, and write it down.